I see a small audience, but they're good quality. So let's begin. We have a tight schedule, and we should follow the times that were given to us for this session. The session we have for today to share with you is about challenges and solutions in the cold chain. We have here Engineer Alejandro Ortega. He's the lead of the cold chain of Nicaragua immunization program with over 20 years working as the head of the cold chain. So he has wide experience in this field. We also have Dr. Lena López. She's the head of the immunization program of Cuba. She's with the Ministry of Health. And we have Claudia Liliana Sosa, who unfortunately couldn't be with us, but will have a video. She's a professional specialized working with the Ministry of Health and Social Protection of Colombia, and she will be presenting a tool that was implemented in Colombia about the management of multiple tools in one portal. So the session is focused on challenges and solutions that countries have faced during the pandemic. COVID was a real challenge for all countries around the world because we did not know what was the vaccine that was going to be used in what platform and with what characteristics. So we started working on some tools that the WHO developed, a sizing tool so we could see the required capabilities in order to have a cold supply chain in our countries. And something important is inventory. Inventory provides very important information because we know what equipment we have, what works, what doesn't work, and also the capabilities that we had installed. And based on these two tools, we were able to face these challenges. But a major challenge was that we had a vaccine at a very low temperatures. No country had these capabilities of having very cold temperatures fridges, but also the personnel trained didn't know how to handle this vaccine at this temperature, but we were able to achieve it with training equipment that was received so we could solve, I don't want to say problems, but complex issues that we had to face. But the pandemic also brought opportunities to strengthen the cold chain, strengthen the supply chain, and that is what we want to present today during this session. Challenges, solutions, how they were faced and how we solved them, and the opportunities we had during the pandemic. So I want to call to the podium Alejandro Ortega, Engineer Alejandro Ortega from the Ministry of Health in Nicaragua. Thank you. Good morning, everyone. Like Nora said, we're going to give you some history of how we faced the pandemic, what we did during and after, and what are the challenges right now. We all know our countries suffered during the pandemic. Our ministries of health were knocked down. We suffered that as well. We were not prepared. However, this allowed us to improve our entire health system. And one of the most important things that we noticed was our storage capability. How are we going to receive as many COVID vaccines if we didn't have the necessary infrastructure, the appropriate equipment? for this batch of vessels. We also had a problem about storage conditions, ultra low temperature. We didn't have this type of equipment. And also the immunization program, as you know, with all of our vaccines, are preserved mainly between 2 and 8 degrees and some at 20 degrees. This was a major issue, a major challenge, ultra low temperatures. The factors that challenged our cold chain was the different presentations of the vaccine, the different population that we needed to vaccinate, and the short shelf lives. Sometimes we had the vaccine, but its shelf life was so short that we had to run and apply it fast. So the deployment of the vaccine had to be as fast as possible. Our country in this region of Central America has a population of almost 7 million people. It has 15 vaccines. Now COVID has been included in our regular program. And in a couple months, there will be the BPH vaccine introduction. I think we are only waiting for the first batch of this vaccine for girls from 10 to 13 years old. This is our logistical structure of our country. It has a national warehouse. This is where all the vaccines are received from abroad. We have the Silais warehouse, which is at the subnational level. It has 19 units. Then we have the municipality warehouse and different health centers, and the health sector, which is the operational aspect of our immunization program. As you can see, all levels are equipped with cold chain, pre-qualified cold chain equipment, from cameras to fridges, cold boxes, thermometers. Everything is pre-qualified. We cannot have a device or equipment that is not a part of the catalog, of the pre-qualified catalog. So we did an analysis of the cold chain. We started from the year 2015 because we were evaluated by our 1.0 by the 1.0 version in the vaccination performance. And back then, we didn't have a lot of monitoring devices to monitor temperature in real time, freezing indicators, spare parts for equipment. And I'll tell you a story. We are a country that almost 80% of our equipment is over 15 years old. So some equipment has been used for 23 years and they're still working. It's still being used. So when that was evaluated, they realized that we have a lot of old equipment. So it was recommended to replace this equipment gradually. And that is something we have been doing. Also, the acquiring of freezing vehicles, the 30-day continuous registration because we use alcohol thermometers. If you remember, it was used before. Also, the recommendation of the construction of 4 regional warehouses, the vaccination inventory controls that is now online. It used to be a standard control, but now it's online. We have at all levels, national, subnationals, municipality, the use of thermal boxes for the vaccine transportation, and the immunization program regulation, which at the end of this month or next month will be finalized and it will be an official set of guidelines. And something very important, which is an updated inventory of our equipment. So from this analysis, We used back then, when the pandemic began, we used 3 systems to keep control of the inventory of the cold chain equipment. We used CCM and we used also IGA, inventory gap analysis tool. We used those two. And this allowed us, when COVID began, we had and we knew where all the equipment was, in which health center, what brand, what serial number, what capability, what population it was being used for, what was the vaccine requirements. We had all that information. The problem was we didn't know what type of vaccine we were going to use for COVID. If it was AstraZeneca, if it was Moderna or Pfizer, we didn't know. So we couldn't calculate. How can we calculate if we don't know anything about the formulation of the vaccine, the type of vaccine? We didn't know anything. So we designed a volume of 30 cc for the vaccine, and based on that, we calculated everything. And we realized with this tool that we had a gap at the national level and a subnational level. And these tools are available. They are by the WHO and PAHO, and this allowed us to know and make decisions in real time. Here you can see what was created with these tools. All of this information that helps us really know specifically, unit by unit. What response did we provide? During the first phase of this plan was to bring to 20% of the population, apply the vaccine to 20% of the population. But the temperature was between 2 to 8 degrees. We never imagined that this was going to be the temperature of the vaccine. When they told us about the temperature of the vaccine, we started running around and wondering, how can we get equipment for this? But the laboratory of the Ministry of Health had new equipment, and they allowed us to borrow this equipment. And that's where we stored these vaccines. And believe it or not, the vaccine was received, for example, today or tomorrow on December 24th. I remember December 24th, and we call a cold chamber provider. We asked them if they had a camera available, and they said, yes, we have it. And on November 24th, they installed the camera, and on the next day, we received the vaccine, and we were able to store the vaccine there. It was AstraZeneca, I remember. But yes, we were able to solve it. Then we bought another camera, and there we began to breathe a little bit. But remember, it was only for a 20% population. Then we received a lot more vaccines. Where are we going to store more vaccines? Now it's not only AstraZeneca, now Sputnik. Sputnik has a huge level of vaccine. It's 20 cc, so that occupies a lot of volume in a chamber. So that really put pressure on us. We had to come up with a strategy for the fast distribution of this vaccine. And also the Sputnik vaccine has to be stored in -20. But when it leaves for the health center, we need to do some sort of labeling. But the strategy that was used in the country is that the vaccination equipment were already inside. So we took the vaccine to the vaccination equipment. So it left in a -20 store facility directly to application site. And that really helped us solve this situation. In 2022, there was a lot more vaccines, so we had a plan to acquire equipment. We were able to procure the equipment through COVA, UNICEF, the Japanese cooperation, and other sources allowed us to procure more equipment, and we were able to strengthen this at the national level and subnational level. On this table, you can see over the years at the national level how we increased the storing capability. And also at the subnational level, we were able to increase storing capabilities. We went from 20,000 liters to 100,000 liters. And we are still working on even increasing these capabilities. And at the municipality level is lower because it's different. The populations are less. So we cannot provide with big equipment because that's not the demand of that population. So what lessons did we learn? In all of this, I always, if we don't have an updated inventory of our equipment, we won't achieve anything. And the inventory of the updated equipment has to be at least on an Excel spreadsheet. I know you can use appropriate systems only for inventory, even better, but we should keep an inventory. This updated equipment inventory is the key to make fast decisions. Look at what happened during the pandemic. We were ready, and I know we were not ready, and I know other countries were not ready either because they didn't have anything updated. Alejandro, you have 1 minute left. I was saying that this allowed us to have a high COVID coverage, and the challenges is that we will implement IGAs on the web, IGA. We will also be providing training for users and operators, and we will continue updating the vaccine registration in JET 2.0. Thank you. Thank you, Alejandro. Definitely, Nicaragua has been working together with the WHO and PAHO, implementing tools that are important for the development and strengthening the cold chain and the supply chain. The use of effective vaccine management, which was 2 or 3 years ago, allowed them to implement new equipment and replace their obsolete equipment. Its IGA has also been important, and all of these tools for the implementation of COVAX. We supported them so they could implement the inventory management tool, which was an additional capability for them. So the work we have been doing with Nicaragua has been very important. And now I want to call to the podium Dr. Lena López from Cuba.
Good morning. Thank you for the organizers, and Dr. Nora for giving me the opportunity to exchange some information with you. We're going to go through this presentation. I'm going to explain to you the immunization national program that we have in Cuba and the strategy that we have for the COVID vaccine, and what were the strategies from the national point of view that did not allow the coverage of the scheme of its routine and the impact of the cold chain. The National Health System Immunization Program had 61 years of been created, and it's integrated at all levels of the health system. It's completely free and it's directed to the population depending their course of life. At this moment, it's against 16 diseases and combined vaccines. 12 are national production and the others are imported, and 5 are administered to risk groups. The introduction of the countries is about the year 2021, and we incorporated the vaccines of COVID. And on 2024, we want to introduce HPV and pneumococcus. Since 1962, the year that the Immunization National Program was founded, we have the first campaign for immunizations. It was 4 months and a half, and it eliminated poliomyelitis. Nowadays, we achieved the control of 3 diseases, the elimination of 3 diseases, and the control of other 7 up until 2021 with the COVID-19 pandemic. When on March 11th, WHO informed about the COVID-19, we had the first 3 cases in the country. 2 months later, the president asked to the biotechnology industry from Cuba the need to develop our own vaccines because there was no possibility to access the vaccines on the market. So on July 9th, 2021, it was authorized by the emergency mandate, and we had the vaccine Abdala. And on July 29, it was approved the mass vaccination of the population above 19 years old. Afterward, we have Soberana 02 and Soberana Plus as 2 other vaccines. Then we have on September 3rd the pediatric vaccination approved, and Cuba was the first country to vaccinate pediatric population. On December 6th, we have the booster shots approved for adults. Amongst the main actions that we had in the country to execute this strategy of vaccination and COVID, we had the design and the assessment and follow up day to day to how to transfer these vaccines to these health centers and not losing the cold chain. We had the need to habilitate more than 11,000 points of vaccination in order to vaccinate our population in such a short time. We had the certification and the equipment of these vaccination points that we use with a routine vaccination. At the same time, we needed to train more than 23,000 nurses and their reserves in order for them to work in these new points of vaccination, and we incorporated medicine students and nurse apprentices to tend to the population. In this way, the population achieved vaccination following the age gaps that we had, and we have social distancing applied. That that was one of the measures that we established in the pandemic control, and we also needed to use more human resources in order to provide a surveillance on the social distancing, and we have surveillance as well additionally for the equipment, and we have another protocol for the people that had disabilities and some of them couldn't leave their houses, so we had on-call and home visits. In this graph you can see the incidency and the mortality of in Cuba of COVID-19 versus the vaccination of COVID-19. As you can appreciate here, Cuba started to vaccinate when the Delta wave was hitting hard, and the number of deaths, we had the highest number with high intensity. And in that moment, we got the authorization on the emergency mandate, and we were able to vaccinate. And on week 36, when 39.2% of the population had a complete scheme, we saw a descent in the number of the death toll. So more than 45.4% had a complete scheme, and we start seeing a decline on the incidency. The death toll is 9. The last death that we had was in August 19, 2022. Without a doubt, you can see in the graph that when you have high coverage of vaccination, we achieve the control of any other disease, no matter the complexity or as new like COVID-19 was. In the particular case of pediatric vaccination, we began in September 3rd, as I mentioned before, when we had the authorization of the pediatric use. And in 2 months, we were able to vaccinate the 97.5% of the whole population. This was a joint effort with the Ministry of Health and the Ministry of Education, where the school centers were habilitated to vaccinate the students. Parallel to this intense work, an extensive campaign of vaccination where we always vaccinated the whole population of Cuba, even if the immunization program we had experiences in previous campaigns. This was the campaign that truly, because of the time and the universe of the population that we needed to vaccinate, was a challenge that we have never seen before. In the same way, we never wanted to forget the coverage of routine vaccination, and we needed to start creating strategies that will allow us to parallelly to execute the COVID vaccination and never lose the conquest that we already had with the coverage of our traditional vaccines. Amongst the main actions that we executed was list of the boys and girls according to their health center areas and the vaccines that they had pending. We used the strategy of active capture through calls and messages and text messages and dissemination in social media to communicate in to the mothers or fathers so they could bring their children to the vaccination points. We had mobile points of vaccination that allowed to find this pediatric population. We had home-to-home vaccination that usually we don't use in the country. It was habilitated. We also took advantage of the opportunities when we had the pediatric population when they needed to go and have medical services and the co-administration of the different vaccines that because of their needs they couldn't have been applied to. We also had scholar vaccination opened again once schools were opened for business again, and this was followed up with a rigorous weekly analysis and from kid to kid in all levels of execution in the Ministry of Health and Health System, so no kid was left behind. In this way, you can observe in this graph how in the pre-pandemic years, the coverages of vaccination had no significant differences amongst the different immunological, and not only on the level of the country, but on the level of the municipalities and the health center areas. We didn't only achieve a national coverage, but we worked up until the subnational sections and the level of the health center areas. You can observe in this figure that you have all of the municipalities that have a coverage of vaccination of more than 95%. This was only possible with the strategy of vaccination for COVID that was developed, and we were able to vaccinate on the traditional scheme with the strengthening that the country received in more than $3 million from PAHO and UNICEF that were supporting us with the acquisition and procurement of refrigerators, turns, and ice packs that helped us to replace some fridges, indicators of thermometers for different fridges, and thermometers of continuous registry of vaccination and control of temperature. In this way, the structure of the cold chain that we had was very much strengthened, eh, especially in the level of the points of vaccination that we had existent. This allowed us to open new vaccination points, as I mentioned before, and we strengthened the home-to-home vaccination. We reinforced scholar vaccination. It elevated the satisfaction of the personnel with the new equipment that was acquired. It allowed the country to have more than 70% of the equipments that they have now with pre-qualified refrigerators. It amplified and extended the storage capabilities with new possibilities for the introduction of new vaccines, and it provided a better guarantee to the control of the temperature and to have pre-qualified equipment as well as the new refrigerators. They were very much useful against power outages and other contingencies that the country faces. Next, we want to have a cold room or cold chamber for the International Airport Jose Marti. We want to complete at 30% of the new points of vaccination with pre-qualified equipment, and we want to have an international workshop of an effective management of the vaccination to provide different tools for implementation. I hope that you have liked my presentation, and overall I hope that you have the capability to, I had the capability to transfer that as an organization with perseverance and teamwork, and above everything, with a joint effort and coordinated effort against and with the UN agencies and the health ministry, you can have high coverages of vaccination. Thank you so much. Thank you so much, Lena. It was an excellent presentation. Up to this point, I just want to invite all of the countries of the Americas so we can have an assessment of an effective management on vaccination. This is something that it's very much important in order to see and have a deep down to understand what's happening with the cold chain, what's happening with the supply chain, and we having this new version of the tool that is a 2.0, and I want to highlight that point as well. The next presentation is going to be a video. We're gonna play the video of Claudia Liliana Sosa of Colombia. We're gonna watch the video and we're gonna have the presentation as well on the screens. Let's go ahead with the video. Welcome to the all the participants. My name is Claudia Liliana Sosa. This is about the information system of the Ministry of Health of Colombia. I want to thank the invitation of this important meeting. I want to talk to you about the nominal information system for vaccination that it's called Pilot in Colombia. Well, in our nominal vaccination information system, this is a system since 2013, and it has the nominal vaccination information of the whole Colombian population. It had an engineering in 2020. This re-engineering provided new modules for the system. Generally, our information systems have some objectives that are to have a better opportunity for the quality of information in order to have a better decision-making process. In this case, we have all of the information and the background of their vaccination schemes in order to understand the coverage of vaccination and to have reliable information for the decision-making process. It allows the traceability of the administration of the vaccines. This is very important to take into consideration that our system has 7 modules that are integrated amongst each other in order to achieve a traceability on the vaccines since it arrives to the country up until it's applied to the patient. We have better inventory and conservation, storage and transportation as a visibility. And for every biological resource, our system has integrated a lot of modules that truly allow us to have the information integrated to have a real-time inventory of the vaccines in the whole country. We achieve an improvement on the efficiency and effectiveness of vaccination, making the information available online. We have an ID for vaccination that is actually generated from the system. And generally, the vaccinators can check their tracking ID of vaccines from the user, and we also have a digital ID that people can have, and through safe devices, they can check them and update them. We also had an optimization in the gathering availability of vaccination data on people, supplies, biological resources, and we have all of the information gathered in the points of vaccination and the health centers, municipalities, and everywhere in the country. And we have great capabilities augmented with all of these modules. In data, we have more than 53 million people created. This was increased in the pandemic because we have more than 100 million dosages. So we have a lot of information that was collected from all of the Colombians and all of the people that live in Colombia, including migrants and foreigners that could have been vaccinated in the country. We have more than 330 million of registered dosages, including the permanent scheme and traditional vaccines and COVID. We have more than 11,000 active users that are about the vaccinators in each point of vaccination where we provide the service, and we have more than 2,600 active institutions. As I was telling you, the system allows us to have a traceability through the system and through different modules. We have the inventory module where we have the control of entries and everything that comes out, and when it goes to the country and it's distributed into their warehouses that we have, it enters to the country distributes according to the vaccination goals to the national warehouses, and from those national warehouses it arrives to the institutions, points of vaccination, or the municipalities. We have an order module where you have a calculation of the biological resources per level and according to the inventory and the necessities that are established in the vaccination system. We have the cold chain module that I'm going to explain further on, and this is a new module that actually allows us to verify the optimal conservation of the vaccine and to understand the capability of the cold network in the country and all of the maintenances that we have in the cold chain that needs to be performed. We have a module of biological management that it's all of the data of the user, basic data of the user, and also specifically we have another module that it's the matrix module where we have dashboards and reports and statisticals, and we can have monthly reports and everything that allows us to have a better decision making process in the country that truly actually strengthens our coverages and vaccination. The structure, as I was mentioning, we have 7 modules. The application module, the application of the vaccine, the traceability of the schemes. We have interoperability of with a lot of other systems of information in our ministries, and we consider the evolution as well. That is in our registry office, where everybody is created in the country. This is an institution that actually is in charge of the civil registry of every civilian and citizen in Colombia. We have the order module. We have the inventory module. This is very much important. That allows us to consult the expiration dates and at every level status, even if it's in the warehouses or in the points of vaccination. Interoperability is available with our inventory system that it's corresponding to the supply, and we have the module where we have everything accounted for. We have a module of the cold chain that has a traceability of the resources management. This is very much important. This is a new module that we wanted to strengthen, and it's integrated in our system, and we can see the changes in temperature there. We can verify as well the inventories of the cold network and the preventive maintenance and corrective maintenance as well. We have the administration and user management as well as audit module. We have a specific rules here that are permitized, and each permit that a person have or authorization depending on the role in the system. If it's a vaccinator, is an administrator, is an a coordinator, or if it's a department coordinator, and then you will get the authorizations regarding the protection of the data of our users. We have a matrix module for biological resources. It doesn't allow to have invalid information, but it's specified to the type of the vaccine. We have a report module. This is a very important module. We have dashboards, coverages, application per department, and we have an interoperability in order to have data cubes and new information. We are in the process of development of an application that's called mobile and strategic, so you can upload the information and we don't have a lag in remote areas where we do not have internet connectivity. As I was talking about the cold chain module, we have a part that is called equipment. We have here the registry of all of the equipment that we have in the country, and we have bequest that is the standard in the country. It has the inventory, the environment temperature, the transfer module, it has the quarantine module, and it has reports because it has a biometric capability in the cold rooms and the maintenance of the equipment as well, and all of the corrective measures that you need to do in the case of control of temperature if it's making the vaccine be at risk. We also have here some of the screens that are created for the inventory. All of these equipments should be registered through the creation of an inventory with a PQS catalog. All of this can be associated to a quarantine. When we lost the ideal temperature for the vaccines, some of them have a concept of a regulatory entity. In this case, for Colombia, it's the ENVIGA. And each responsible entity is responsible for the maintenance of their cold rooms and their cold chain equipment, refrigerators, thermometers, etc. Here we have a maintenance screen, and we have the module of temperature where we have the loss. We report in BIMA. You have every support uploaded to verify if the vaccine can be used or not, depending on that. And here we registered it in the system. Logically, we have a quarantine. If we don't have a concept of the regulatory entity, in this case, it's INVIMA who made the evaluation. If the vaccine lost its adequate temperature in order to be viable. This is all. I truly want to thank your participation in this important conference and giving me the opportunity to participate. Any questions, and a million blessings to you all. Thank you, Claudia, Liliana. You were online, but because of time, we will not be able. Maybe one question. One question. Let's have one question in English and one in Spanish, so we are prepared. Let's begin with one question in Spanish first, and then we will go ahead and have one question in English so the moderators are ready to use their headphones. Please raise your hand if you have a question. Thank you. Thank you so much. First of all, congratulations to you all because it has been spectacular achievements in your presentations in your own way. So, congratulations. First of all, Cuba. I want to understand a little bit more. This is more about the service delivery. But in order to elaborate all of the coverages that you achieved and you implemented any type of communication action for a behavioral change that was parallel. So, because it's a great achievement, so it will be very interesting what other things were there. And for Colombia, I want to ask with all of the system, I'm not clear because you were talking about that you register migrants. Generally, the migrant population don't want to have their names or their information, especially if they are illegally in the country. So how do you deal with that registration of those people and they are not identified as illegal migrants? So, for example, if you're doing any type of study regarding boys and girls that have received no zero dose, you have any type of action in order to rescue those people? If this magnificent system is helping you to increment the coverage because of the information that the system is reporting you back. Thank you, Elena. Well, thank you so much for the congratulation. Oh, yes, of course, every type of campaign that we have in vaccination, we have a communication campaign as well to try to sum up all of the work we did in the time that I had for the presentation. It's way too hard, but it was accompanied by a communication strategy by TV, radio, press, bulletins, community work to the level of the health centers. Say we have the point of vaccination. You have observed that I mentioned that we had students and apprentices. They had the task as well to go house per house and provide a flyer and provide actually the appointment that they had at one time they needed to get their vaccines, because if you don't do that organized in an organized ways, you can collapse the points of vaccination. So all of the persons that we have in their section of health, and everybody has there one family nurse and one family doctor that tends to one determined population, they actually were like there are point of vaccination, and that vaccination point that we had and all of the students and the apprentices that we had and that doctor and that nurse that work in that population, they visited the house and they gave them an appointment for their vaccination. And we used the radio, used TV, blog, bulletins, a complete communications strategy. Nevertheless, the country was very much used to perform campaigns of vaccination very much frequently. For example, with polio, we used and we employed the oral polio, we use a vaccination campaign. So the country and the population, it's very much aware of doing performing this activity, that it's not new for us, and it implied a big challenge in the universe that we had to vaccinate, which was huge, and we were facing a huge challenge this time, but it worked. Right, let's see how this will work, because I have Claudia, Liliana here and the cell phone. So technology, maybe it needs to be used, but sometimes it's a little bit difficult. I have her here on the cell phone. Claudia, Liliana, can you hear us? Hi. Can you all hear me? Yes. Go ahead. Greetings. I want to answer the question. On information system in the country was standardized by through different types of documents. For example, for migrants, it was a temporary authorization for staying in the country, or other types of documentation that we have in order to register the people in the system. They have a temporary authorization or permit. In the case you are a migrant, we had a standardized documentation that we provide them in order to have an uniformity in the registration of this migrant population, understanding that in Colombia, if you have a permit or you have a foreigner's ID, or depending on the type of document, for the case of the next question that had to do with the search of these people with zero dose, we have a module in our information system where we have the birth date and the vaccination date. We check that and match that to see who have not received the service and need their vaccines. We provide this to the point of vaccinations that and the territorial authorities that do the management with the points of vaccination to search for these people. One challenge that we have and we're strengthening is the reorganization geographically of the people that we need to vaccinate, so we can locate them and we can vaccinate them. This is an improvement that we're working on and we're trying to establish in the system in order for us to locate the susceptible people, and we have this opportunity of vaccination. Thank you, Liliana. Any questions in English? A microphone, please. Microphone. Okay, I've just been informed that because of time, we are not going to be able to take the English question, but please, I will invite you in the coffee break and in the lunch to ask to the participants of this session. And to all of you, we truly want to thank you for your participation, for accompanying us, and for the moderators. Thank you so much, panelists, and thank you. And let's keep in contact, please. Thank you so much.